Now we will see intraoperative care. In that we are going to discuss about what are all the intraoperative care bundles. The intraoperative phase encompasses the time from when the patient enters the surgical suite throughout the surgical procedures and until the surgery is complete and the patient moves to the post anesthesia care unit for recovery. In intraoperative care, first we will see surgical hand scrub. Hand hygiene is a critical infection prevention, functions in all phases of care for the surgical patient. Personnel should follow their hospital policy for hand hygiene at all times. Surgical hand antiseptics helps to cleanse a healthcare worker's skin and removes debris and transient microorganisms present on their nails, hands and forearms. It also reduces the resident flora and slows the regrowth of microorganisms. Healthcare workers who are preparing to move into the surgical suite, they should perform their hand scrub process according to the established facility policies and procedures. Next, we will see intraoperative skin antiseptics. Antiseptics for skin preparation are important to reduce debris and transient and residual flora. It is generally agreed that the most effective surgical skin preparation solutions are dual agent containing alcohol plus another antiseptic such as chlorhexidine or iodine, which provides rapid, persistent and cumulative antimicrobial action. The most current CDC's SSI prevention guidelines supports this as a strong recommendation, stating that perform intraoperative skin preparation with an alcohol based antiseptic agent unless it is contraindicated. The WHO also recommends strongly the use of an alcohol antiseptic solution based on chlorhexidine surgical site skin preparations for patients undergoing surgery. Then antimicrobial prophylaxis and redosing. In the intraoperative phase prior to the incision, the surgical antibiotic prophylaxis is administered to provide a concentration of the drug in serum and tissues that is at a bactericidal level when the incision is made. The surgeon will make the decision about antibiotic administration and redosing based on the patient's weight and expected pathogens. The purpose of redosing is to maintain adequate tissue levels when the surgical procedure is prolonged. The antibiotics should be redosed periodically based on length of the procedure and 2 half-lives of the drug. Then move on to traffic control in the operating room. When the surgery has begun, managing traffic flow is important to reduce air turbulence, which can disrupt and resettle any particulates on horizontal surfaces, which may then become laden with microorganisms. Traffic flow is managed by the number of people entering and exiting should be kept to a minimum. The door to the surgical room should be kept closed because opening and closing the door can disrupt the air pressure balance, which can increase dust particles and microorganisms in the air. Ensure that all anticipated supplies, equipments and personals are in the room when the procedure starts. Less traffic reduces the risk of accidental contamination of sterile supplies. Then we will see the importance of normothermia during perioperative phase. Hypothermia occurs by triggering vasoconstriction, leading to reduced level of oxygen in the tissues, which impairs the ability of neutrophils to kill organisms and therefore decrease the wound's ability to heal. Loss of body heat occurs after induction of anesthesia and continues throughout the surgical procedures. Even mild preoperative hypothermia, which is common during major surgeries, also may increase the risk for SSI. Studies have shown a decreased risk of SSI in patients undergoing colon surgery when the body temperature is maintained at or above 36.5 degree Celsius. So the recommended body temperature during intraoperative phase is 36.5 or greater than that. Next, we will see perioperative supplemental oxygenation. WHO recommends that adult patients who are having anesthesia with endotracheal intubation should receive an 80% FiO2 both intraoperatively and in the immediate postoperative phase for 2 to 6 hours to reduce the risk of SSI. The 80% FiO2 is associated with a decrease in SSI compared to an FiO2 of 30% to 35%. So, careful monitoring of the oxygenation level is part of the overall strategies to reduce risk of infection beginning in the preoperative phase and continuing in the intraoperative and postoperative phase as well. Then we will see management of blood glucose level during perioperative period. Managing the surgical patient's blood glucose levels and addressing hyperglycemia during surgery appears to help reduce the risk of SSI. Strict blood glucose level targets are beneficial in reducing SSI rates when compared to more conventional protocols. The WHO and the CDC suggest the use of protocols for intensive perioperative blood glucose level. Targets for glucose control is vary. So the CDC recommends a target of less than 200 mg per deciliter in patients with and without diabetes. In diabetic patients undergoing open heart surgery, the acceptable glucose level is maintained preferably below 180 mg per dl. Blood glucose management is important for all patients to help achieve a lower SSI risk. Thank you for watching this video.